I'm going to go on and talk about some of the treatments of bipolar disorder, specifically medical treatments. um, Traditionally, the mood stabilizer agents are lithium, Depakote, and Tegretol. Lithium is technically a salt. It's a naturally occurring salt. It's on the periodic table of elements below sodium and potassium. And lithium was found by accident by an Australian doctor who, I can't remember all the reasons, but did some type of study with rats and put it in their water and found that they calmed down. And from those observations started giving lithium to patients in his hospital who were agitated, and found that it calmed them down. Well, over some time and systematically studying it, it was found that it was very effective for a number of people with manic depressive illness, or what's been come to be called bipolar disorder. And we don't know exactly how it works, but like other salts, it does carry an electrical charge in the body. Like sodium has a +1 charge, lithium has a +2 charge, and it's felt to stabilize nerve membrane firing, although it's more complicated than that. At least it's felt to be. The fact that it stabilizes nerve firing led to some studies of anticonvulsant medicines like Tegretol, carbamazepine, and Depakote, valproic acid. Actually, some studies by Japanese psychiatrists on Tegretol or carbamazepine got us into the use of anticonvulsant medicines. They noticed a similarity between their patients that had temporal lobe seizures that are specific or localized in the temporal lobe, and patients that had bipolar disorder in terms of drastic emotional changes. And the drug of choice for temporal lobe seizures at that time was Tegretol, or the generic carbamazepine, and so they decided to try Tegretol on individuals with bipolar disorder and found that it was helpful to a number of them. This led to trials of several different anticonvulsants, and over time it's been found that Depakote is probably one of the most effective anticonvulsants for bipolar disorder. Again, lending some credence that there is an electrical abnormality in the nervous system, maybe even a subclinical seizure in some cases. Another anticonvulsant, Lamictal, or lamotrigine, is used in treating bipolar disorder, but is more effective for the depressed phase of bipolar disorder rather than for the manic or the cycling. That gets us into another class that are called the neuroleptics, or the atypical neuroleptics, which is the newer generation. Used to be called the antipsychotic medicines, which have been found over time to be very effective for bipolar as well. And a number of them have been FDA approved for treating bipolar disorder, some of them even to very young ages. Abilify would be one of these. Risperdal would be another. Seroquel, Geodon, and then there's some newer ones as well. Latuda, like Lamictal, has been found to be more specific for the depressed phase of bipolar disorder. These work more on the chemical level by blocking certain chemicals. The old hypothesis on this was their effect on the dopamine system, although their effects are much more complicated than just that, especially the newer agents. One of the problems that I've experienced, especially in individuals that are recovering from addiction, is somewhat of a reluctance to be treated for bipolar disorder although it isn't just an issue with people recovering from addiction. There actually are studies, there's been at least 3 well-done studies showing that individuals with bipolar disorder take about 10 years and 3 different clinicians before they get accurately diagnosed, often because they present more when they're depressed, and often because clinicians don't ask enough questions when they are depressed to sort out whether the depressed phase they're in is part of a bigger problem, which is that they get manic or hypomanic at other times. But people are times resistant to the diagnosis because of some stigma, and whereas the traditional mood stabilizers like lithium, Depakote, and Tegretol can take some time excuse me, to treat, and require levels, blood level monitoring. The atypical neuroleptics, say like Abilify or Risperdal or Invega, often can be effective very, very fast. But people sometimes have ambivalence towards treatment, and so they will take the medicine reluctantly and sometimes only partially, or at the first sign of any side effect will justify not taking it, and so sometimes the trials are not done very well. And what I found over time is that after a few doses of medication, of say the atypical neuroleptics, just to make sure that people don't have adverse reactions, that using the long-acting depot injections that last for a month can be a very effective way of treating the condition, because in those situations the medication then is in a person's system for several weeks, and they get a chance then to really see how they do with it. The depot injections go into the muscle. Medicines absorb gradually into their bloodstream. They get a very smooth blood level. In some cases may have less side effects, but they're stuck with the medicine at that point for 3-4 weeks. And in many cases I've seen people then accept the treatment because they see such a dramatic change in how they do. And I have several people who then pick up their their next injection at the pharmacy and bring it in and tell me when it's time to get it, because they know when it's wearing off, and they want to make sure they get it, which sometimes kind of stuns me that they're so on top of it, because they can see such a big difference in their life when they're on it. The injection of Risperdal lasts 2 weeks at a time, so it has to be given twice a month. The injection of Abilify, there's 2 forms, one that's called Abilify Maintaina and a newer one called Aristada, lasts a month, or Aristada may last even longer, up to 6 weeks. And Invega lasts for a month, although there's another form of it called Trinza. When you've been on the month injection for a few months, you can switch to the Trinza, and that lasts 3 months at a time. So a person would only need to get that 4 times a year. The Risperdal Consta is the only one that's FDA approved for bipolar disorder. The Abilify injections and the Invega injections are FDA approved for schizophrenia and for schizoaffective disorder, but can be used off-label for bipolar disorder, which I do frequently, because the Abilify orally is FDA approved for bipolar disorder, and Invega is actually a metabolite of Risperdal. So you're not making any real great leaps in using the long-acting injectables for bipolar disorder, and probably with time they will be FDA approved for bipolar disorder as well. Treating bipolar depression can be very difficult because standard antidepressants you can win the battle but lose the war when it comes to bipolar. It can help people get out of a depression, but then may send them into rapid cycling. It can be putting gas on a fire, and they may have more mood episodes or ultra rapid cycling, or even convert them into mixed phases where they have depressed and manic symptoms at the same time the longer they stay on these agents. Some studies have suggested Wellbutrin may be less apt to do this. In other cases, the bipolar depressed phase is just less responsive to traditional antidepressants. As I mentioned, Lamictal, the anticonvulsant, and Latuda, one of the newer atypical neuroleptics, have been FDA approved for treating the depressed phase of bipolar disorder. And interestingly, some of the stimulant type medicines have been showing some promise in treating the depressed phase of bipolar disorder. Some of the narcoleptic medications like Provigil and something like Vyvanse may have some role to play as well in treating the depressed phase of bipolar disorder. Another aspect of treating bipolar disorder medically is that you don't establish a medication regimen, which often includes more than one medicine that's working in more than one different mechanism of action to get an optimal effect, and then just go your merry way, because over the course of time, due to stress, due to the seasons of the year, or other factors that we can't fully understand, maybe hormonal fluctuations, the situation changes, and you have to make adjustments in the medication. Sometimes a little more mood stabilizer and a little less treatment for depression. Sometimes a little more treatment for depression with a little less mood stabilizer. And I sometimes will use a brake and gas analogy, that sometimes we need a little more gas and a little less brakes, and sometimes we need a little more brakes and a little less gas. And things that we'll key in on are sleeping patterns, appetite, energy levels, sex drive, as well as the mood state, and whether it's low or high, or cycling, and making decisions about adjusting medications in one direction or another. And often it takes a good year of working with someone to help them be able to cue into the changes that are occurring in some of these physical symptoms, and be able to start to alert me when a change is needed, because they can pick up on these things a lot sooner than I can once they get to know themselves and know how these things relate to their mood disorder and how it relates to the need to make changes in their medicine. And over time, people can get so good at this that they can know what needs to be done and adjustments that need to be done in their medication, and can get pretty good at it when they take it seriously. So that's a quick overview. There's other aspects of it, but I think that'll serve as a quick, just a quick overview of medications for bipolar disorder. Thank you.